This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Thank you so much for joining us at Fellows Conference. Today we have Dr. Nishant Vatsa, who is one of our academic clinical investigator pathway fellows. He's currently in his second year of clinical time and will be doing a imaging fellowship next year, a structural imaging fellowship. All right, Nishant, take it away.
Thank you so much, Dr. Coley. Thank you for that kind introduction. So I'm here to present something that I haven't seen presented in these conferences on Friday as much. So I thought it'd be a good topic to go over today, which is congenital ventricular septal defects in adults. And we'll get started. So today I want to review a case with ventricular septal defect. And then go into the topic, which is congenital ventricular septal defects in adults, and review the embryology and anatomy of the interventricular septum, which will kind of give us a good basis of understanding these defects. And then finally, review the clinical manifestations, diagnosis, and the management of congenital VSDs in adults. So let's get into our case. And our case really starts about 2 weeks prior to the index presentation, and where we found a defect in this patient. So it is a 58-year-old male, about 2 weeks before the index presentation, a 58-year-old male with a past medical history of hypertension, diabetes, polysubstance abuse, cocaine, and alcohol, who presented after a motor vehicle accident. He was unrestrained and sustained blunt force trauma to the chest, which resulted in multiple right-sided rib fractures, sternal pylon fracture, pulmonary contusion, retrosternal hematoma, and a small left hemothorax. And so cardiology was initially consulted because he came in to trauma. They got troponin, which was elevated, actually peaked in the 4,000s and subsequently went down. This was thought to be due to myocardial contusion, but what was most concerning was his initial EKG showed a high degree AV block versus a complete heart block. And so cardiology was consulted, and this was his initial EKG, and you could see there was AV dissociation between the A's and the V's, considering a complete heart block. And so we recommended further imaging with an echocardiogram. And this was the initial echocardiogram that was got in this presentation. And as you can see, this was read as a patient with normal systolic function, but what they noted here was a moderate TR. However, I thought it was kind of interesting looking at this, image is that, this is kind of an abnormal jet for a TR. It seems like it's almost coming from where the septal leaflet of the tricuspid attaches to the septum. And then here's another image from that same echocardiogram. And as you can see, the jet almost seems like it's going from the left ventricle to the right atrium. In any case, this was read as a moderate TR with the RV systolic pressure of 45. And so the patient was monitored, and his orthopedic injuries were non-surgically. There was no surgical intervention. It was treated medically, and he was kind of monitored for the next week to see if his complete heart block kind of dissipated. Unfortunately, on telemetry and EKGs about a week later, they saw that his complete heart block, albeit he was hemodynamically stable, persisted, and so it was determined that he would need a dual chamber pacemaker, which he got during this hospitalization, and he was subsequently discharged. Not even a week after, about 6 days after discharge, the patient actually represented, and this time he was in acute hypoxic respiratory failure and was found to be volume overloaded. His BNP and troponin presentation was 368 and 20 respectively, and the CT chest on presentation showed a large left-sided pleural effusion and was suggestive of hemopericardium. And so he was admitted to the SICU to get a chest tube, and cardiology was consulted in the setting of hemopericardium in the setting of recent dual chamber pacemaker placement. And so an echo was ordered to evaluate for hemopericardium. And as you can see here, you don't really see any, substantial pericardial effusion, but in the subcostal view, you can kind of see a jet going from the left ventricle to the right atrium. And again, this jet was read in this echo as a moderate to severe tricuspid regurgitation at this point with an RV systolic pressure of 60 to 70. And this is kind of this from the same echo, but a different view, putting the color on a different aspect of the subcostal view. And as you can see here, there is a jet going in the right atrium, but it seems very peculiar to be TR. Because there was no hemopericardium, we signed off. The patient was subsequently kept in the SICU and eventually transferred to floor, but he was found to have persistent hypervolemia that was resistant to pretty aggressive diuresis, and they were getting a lot of fluids off of him. And the patient was net negative 3 liters, and he was still having hypervolemia. And so the primary team actually decided to get another echo, and this time they did it with the bubble study to evaluate if there's any role of shunts in his hypervolemia. And this is the echo they received about 10 days after the last echo I showed you. And as you can see here, when they put in the agitated cylinders, clearly bubbles go from the right atrium to the left ventricle. And so cardiology was consulted, and upon seeing that, there was appropriately immediate concern for a defect called a Gerbode defect, which I will go over later on. And so we advised to get a MRI image. And as you can see on this MRI image, you can see flow going from the left ventricle to the right atrium, which is pretty characteristic of this Gerbode defect. The patient eventually got a left and right heart cath. The left heart cath didn't show any obstructive coronary artery disease. The right heart cath, actually, interestingly enough, it showed normal cardiac output, elevated right atrial pressure around 13. Interestingly enough, the right ventricular pressure was normal, about 30/12, and the PA pressure, the mean PA pressure was around 16. The pulmonary flow, the systemic flow ratio was about 1.38. And so the patient was eventually transferred to Emory Midtown for further management, and we'll get back to this case, but I think it's a good time to break off to start going over the topic of congenital ventricular septal defects in adults. And I do acknowledge that in this particular case, this Gerbode defect was likely acquired from the trauma, but a lot of Gerbode defects are actually, inherited, are congenital. And so I thought this would be a good case to lead into this topic that we haven't really gone over during fellows conferences. I think recently we had a conference on mechanical complications of VSD, so I thought it'd be good to go over congenital ventricular septal defects in adults. The prevalence and etiology. The prevalence of these defects is second most. It's the second most congenital defect amongst adults, behind bicuspid aortic valves. It accounts for about 10% of the congenital heart defects in adults. And the etiology is thought to be environmental, combination of environmental and genetic factors. I've listed some genetic polymorphisms here that have been associated with congenital VSDs. Also, there are some genetic syndromes that are associated with genetic VSDs, trisomy 13, trisomy 18, and trisomy 21. You may recognize trisomy 21 as Down syndrome. Now, I think as we move forward, I think it's important to go over the embryology of the interventricular septum, how it's created. That will give us a good understanding of not only how the anatomy of the interventricular septum, but how these defects may form. And just to orient you, on the top, you can kind of see a compass. Going from the left to the right of the slide, we're going from dorsal to ventral. And then from the bottom to the top of the slide, we're going from caudal to cranial. At about 3 weeks gestation, the heart is essentially a tube. And then going from caudal to cranial, you have the sinus venosus, which is the main venous return of the heart tube. You have the primitive atrium, which eventually develops into our atria, the primitive ventricle, which eventually develops into trabeculated left ventricle, and then the bulbus cordis. The proximal bulbus cordis eventually develops into the trabeculated right ventricle. The more distal portions form the conus cordis, which eventually form into right ventricular and left ventricular outflow tracts. And then you also have the truncus arteriosus, which forms the aorta and the pulmonary artery. And about the rapid growth of the primitive ventricle and the bulbus cordis causes this heart tube to start bending and folding. And so it starts bending and folding ventrally and caudally, and it has a rightward rotation to eventually form the following structure. And this is kind of a lateral view of the heart at about 5 weeks gestation. And going from dorsal to ventral, you see kind of what would eventually become the atria. You see the AV endocardial cushions, and you see the bulboventricular cavity, which is formed by the proximal bulbous cordus and the primitive ventricle. And then you have the conus cordus on top. At about 5 weeks gestation, the floor of the bulboventricular cavity kind of goes upwards. This makes up the first part of the interventricular septum, which eventually turns into the muscular septum. And there is a slight opening in the bulboventricular cavity that's not covered by this upward outgrowth of the cavity. And this is the interventricular foramen. Thereafter, in the conus cordus, there are these bulbar ridges, an anterior lateral bulbar ridge and posterior medial lateral bulbar ridge, and they start growing towards each other and downwards into the interventricular foramen. Eventually, what this creates is a conal septum, which also continues to grow downwards into the interventricular foramen. And this conal septum actually creates the tracts that eventually will become the right ventricular and left ventricular outflow tracts. Now, I know I'm showing this sequentially, but while these bulbar ridges are growing towards each other and forming the conal septum and growing downwards into the interventricular foramen, you also have the arterioventricular endocardial cushions, which are growing into the interventricular foramen, and they eventually fuse with the conal septum to form the membranous septum. And then I also have over here, I'll go into it more in detail shortly, the inlet septum, which is also formed by outgrowth of the arterioventricular endocardial cushions into the interventricular septum. That's kind of a brief overview of the embryology, and I think that will help us understand the interventricular septum anatomy and how the interventricular septum is divided up. So there are 4 main divisions of the interventricular septum, and all of these divisions are derived from the embryogenesis. So the first one, probably the one we're most familiar with, is the muscular or the trabecular muscular septum, which comprises of the septum from the mid to apical aspects and the anterior aspect of the septum. And it basically comprises most of the septum and gives it its contractile and structural strength. The inlet septum lies at the base of the septum, kind of the inferior base of the septum, and it's below the arterioventricular and valves, which are the mitral and tricuspid valves. And again, it's formed by kind of the ingrowth of those arterioventricular endocardial cushions. And kind of what separates the inlet septum from the trabecular muscular septum is the attachment of the tricuspid septal leaflets. Then you have the membranous septum, which is formed by the fusion of the conal septum and the arterioventricular endocardial cushions. And this kind of lies in an adult and at the base of the septum, kind of the anterior base of the septum, and it is below the crista supraventricularis. The crista supraventricularis is a muscle bundle in the right ventricle, which connects the free wall of the right ventricle to the septum and kind of separates the right ventricular inflow tract from the right ventricular outflow tract. And the reason why I note this the structure is because it's an anatomical landmark that kind of forms the boundary of the membranous septum and the outlet septum, because the membranous septum is below the crista supraventricularis, whereas the outlet septum is above the crista supraventricularis. And the outlet septum, otherwise known as an infundibular septum, kind of separates the left ventricular and right ventricular outflow tracts. So that's kind of a brief overview of the anatomy of the interventricular septum. Now going to the defects. The defects are kind of separated by types based on their anatomical location. Type 1, or the infundibular defect, as it's named, the defect in the infundibular or the outflow septum. This is a relatively less common defect, only happening in about 6% of individuals with VSDs. It's more common in the Asian population, comprising about 33% of VSDs in that population. This defect sits above the crista supraventricularis and below the pulmonic and aortic valves. And this anatomical location kind of dictates how these defects kind of clinically manifest. And so quite often what you'll see with these defects, because of its proximity to the aortic valve, is prolapse of the right or left aortic valve cusps into this defect. And how this happens is, as there's left to right shunt through this defect, you have a Venturi effect, which kind of causes these cusps of prolapse into this defect. And this subsequently causes aortic root dilation as well as aortic regurgitation. There are certain retrospective cohort studies that show that of as much as 25% of individuals with infundibular ventricular septal defects have aortic regurgitation, 10 to 20% have some degree of aortic root dilation without aortic regurgitation. So it is quite a common thing to see in individuals with this type of septal defect. And it's important to note that these individuals can have progression of their aortic regurgitation. There was a retrospective study from Mayo that showed that about 14% of these individuals have progression of their aortic regurgitation. So it's perhaps something that's important to surveil in individuals with infundibular ventricular septal defects. Membranous defects are the most common defect that we see, comprising about 80% of ventricular septal defects in adults. They're adjacent to as I mentioned before, these defects are in the membranous septum, which is adjacent to the tricuspid valve, as well as the aortic valve. So as you might imagine, you might see tricuspid valve abnormalities or aortic valve abnormalities with these defects. In fact, sometimes you'll see the septal tricuspid leaflet prolapsing into this defect, which would subsequently cause TR. And then additionally, kind of like in the infundibular VSDs, you could see aortic valve prolapse into these defects, which will eventually cause aortic regurgitation. It's important to note that aortic regurgitation is much more commonly seen in infundibular VSDs than membranous VSDs, but it's just something important to note that can happen with membranous VSDs as well. These actually can spontaneously close. There was one study that showed about 10% of these defects closing in adults. And then one type of membranous defect to note, and kind of relating back to our case, is the Jaboti defect. And this is a membranous defect in which the left ventricle communicates directly with the right atrium. And what's unique about this type of defect is that this type of defect will cause enlargement and initial enlargement and initial elevation pressures of the right-sided chambers. And this is different from all other VSDs that we're discussing, where all other VSDs, they'll cause initial enlargement or elevation and pressures in left-sided chambers. So that's kind of a neat, unique thing seen in the Jaboti defect. The inlet defect is a defect in the inlet septum. This is the least common amongst adults, comprising about 4% of VSDs. And because the defect is in the inlet portion of the ventricular septum, which is proximal to the mitral valve as well as the tricuspid valve, you could see MR and TR as a clinical manifestation of this defect. And because the inlet part of the interventricular septum is comprised, it develops embryologically from, ingrowth of the endocardial arterioventricular cushions into the interventricular foramen. These defects are commonly associated with AV canal defects because the AV canal and the atrial septums are also, formed by these endocardial cushions. So defects of these endocardial cushions into the interventricular foramen you could also see ASDs and other AV canal defects. And this is the defect that you quite commonly see with trisomy 21. The second most common defect that we see is the muscular septal defects, and these comprise about 10% of VSDs, which is less common than what is seen in children. And they could be single or numerous. And these occur away from the valve, so you're less likely to see valvular abnormalities as a result of these septal defects. And these can quite often be closed percutaneously. Now go into clinic complications and clinical manifestations of these defects. I kind of mentioned some of these clinical manifestations, but The complications and clinical manifestations are largely dependent on location, which I've alluded to in the past couple of slides, as well as the size of the defect. And how these defects are sized are usually by way of the pulmonary to systemic flow ratio, or how big the defect is in relation to the aortic annulus. Small defects typically have a pulmonary to systemic flow of less than 1.5. Moderate defects have a defect size that's 25 to 75% of the aortic annulus diameter. And large defects have a defect size that's greater than 75% of the aortic annulus diameter. And as I mentioned, one complication or clinical manifestation are the valve abnormalities, which I mentioned before, AR or PR with infundibular defects, AR or TR with membranous defects, TR and MR with inlet defects. And then also individuals with VSDs could also have endocarditis. And typically these are right-sided because of the left to right shunt. The risk of endocarditis among those with VSD in retrospective cohort studies, the incidence has been estimated to be about 15 to 24 per 10,000 patient years. And this risk gets lowered once the VSD is repaired. So the risk of endocarditis among individuals with unrepaired VSD is about 3 times the risk in those with repaired VSD. You could also have arrhythmias, as you may imagine, especially when there's chamber enlargement and elevated pressures. One study reported an incidence of about 5.4% of ventricular tachycardia in those with VSD. And this incidence actually got higher if the individual developed pulmonary hypertension as a result of their VSD. Another study showed about 12% of individuals with small membranous VSDs having some sort of atrial arrhythmia. And then things that we're commonly taught about in med school is, obviously heart failure can occur with VSDs. And most commonly, this is left-sided heart failure with the exception of the Gervodi defect. And these mostly occur in moderate to large defects. You don't see this as much in individuals with small defects. And, we're seeing this exceedingly, it's becoming rare to see this in adults because a lot of these moderate to large defects are intervened on in children. Similar with pulmonary hypertension, you commonly see these in individuals with moderate to large defects, but we're not seeing this as much in adults because a lot of these moderate to large defects are intervened on in children. If these moderate to large defects are not intervened on when they're a child, you could see kind of Eisenmenger syndrome developing between the second to third decade of life. And a unique clinical manifestation or complication of VSDs is the double-chambered right ventricle. So what happens because of the left to right shunt, superior to the VSD, you'll see hypertrophy of the muscle bundles of the right ventricle. What this creates is basically a proximal high pressure chamber in the right ventricular inflow and a distal low pressure chamber in the right ventricular outflow. And this can cause right ventricular obstruction, and it can cause dilation of the right ventricle and the right atrium, which can eventually lead to arrhythmias. And quite often, those who develop double-chambered right ventricle, symptomatic double-chambered right ventricle, they will require interventions to kind of remove those obstructing muscle bundles. Now, when should we suspect VSDs? I think a great first step is the initial evaluation with the physical exam, EKG, and chest X-ray. So what is commonly tested and what you will commonly hear on physical exams is a hollow systolic murmur at the left sternal border. This murmur is louder if the VSD is smaller or if the right-sided pressures are lower. And this murmur will become softer as the VSD gets larger or the right-sided pressures and pulmonic pressures get higher. You might also see sequela of pulmonary hypertension or left atrial, left ventricular enlargement as a result of VSD. So you might hear a loud P2, which is indicative of pulmonary hypertension. And because of the increased flow to the left side of the heart, you might hear a diastolic mitral flow rumble. On ECG, you could see sequela of left-sided chamber enlargement or high pulmonary pressure. So you could see findings of left ventricular hypertrophy or LA enlargement, or right ventricular hypertrophy in those with pulmonary hypertension. On chest X-ray, similarly, it's likely to be normal in small VSDs because you're less likely to have enlargement of the left-sided chambers or pulmonary hypertension. But in moderate to large VSDs, which cause left ventricular and left atrial enlargement and can cause pulmonary hypertension, you might see, that on chest X-ray or increased pulmonary markings. But the bread and butter, kind of the foundation of diagnosis of VSDs, is echocardiography, whether that be surface echoes or TEEs. And these are great in not only identifying the VSD, but identifying where the VSD is, which I'll go into in a second. And they can help identify complications of the VSD, such as chamber enlargement or elevated chamber pressures. Sometimes, as we saw in our case, agitated saline could be used to help identify a VSD, especially if there is elevated pulmonary pressures or elevated right-sided pressures that would, prevent color Doppler from kind of identifying the VSD. And then also, as we saw in our case, CMR is particularly useful in identifying VSDs, identifying not only like the defect anatomy, but also giving us more information about heart chamber size and function, helping us quantifying the pulmonary to systemic flow. And there are apical VSDs which may be hard to identify on echocardiography, and that's when CMR can become useful in identifying those VSDs. Cardiac catheterization is also quite useful in the workup for VSDs. They help us identify the pulmonary to systemic flow ratio. And this modality is especially important when we're suspecting high pulmonary pressures or right-sided pressures, as we could directly measure the pulmonary pressures and the right-sided pressures with catheterization, which might influence how we treat the patient. Now, this is a figure I got from a Congenital textbook. I think it's a good figure to go over because it shows just how useful echocardiography can be in identifying not only identifying VSD, but the location of the VSD and the type of VSD. And so these 5 images are kind of standard images we receive from surface echoes. I'll first go with the parasternal long axis view. And what's enclosed, if you see a defect in the base of the septum in this view, you should be thinking that this is either a membranous defect or an infundibular defect. As you can see, this is kind of located below the aortic valve. And as I mentioned before, membranous defects and infundibular defects are kind of proximal to the aortic valve. However, you see a defect in the mid to apical portions of the septum in this view, you should be thinking that this might be more of a muscular defect. In the short axis view at the level of the aortic valve, this is a very useful view in kind of identifying whether the defect is membranous or infundibular. Now, if you think of the aortic valve as a clock, if you have a defect that's going from kind of 9 o'clock to 12 o'clock enclosed in the square over here, you should be thinking that this is a membranous defect. And this makes sense, right? The portion that I have encircled here is by the tricuspid valve, which is where a membranous defect should be. However, if you have a defect that's kind of going from 12 to 2 o'clock by the pulmonic valve, you should be worried more about an infundibular defect. And then fanning down in the short axis view, as we get to the level of the valves, if you see a defect kind of in the inferior septum, you should be thinking that this is an inlet defect. Or if you see a defect more anterior, you should be thinking this is a muscular defect. Similarly, in the 4-chamber view, where we have a good view of the inferior septum, you should be thinking that if there's a defect at the base of the septum, you should be thinking that this is an inlet defect. However, if there's a defect in the mid to apical portion of the septum, it's more likely to be a muscular defect. And then if we rotate our probe a bit to get a 3-chamber view or a long 4-chamber view, where we kind of bring in the anterior septum more into view, if you see a defect at the base of the septum, that's more likely to be membranous. If you see a defect from the mid to apical portion of the septum, that's most likely to be muscular. So as you can see here, just from our standard views on the surface echoes, you can not only identify a ventricular septal defect, but identify the location, which is important because the location heavily influences how the clinical manifestation of the ventricular septal defect. Now, how do we manage these defects? Basically closure, defect closure, and this is mostly done surgically. However, membranous or perimembranous defects or muscular defects can be closed percutaneously, and that's by case basis. And what are the indications for closure? So class 1 indications, left ventricular volume overload with significant left to right shunt, which is defined as a pulmonary to systemic flow of greater than 1.5. And if they don't have significant elevation PA pressures, and I'll go into that in just a second. The class 2A recommendation, and this is why it's important to determine the type of defect you have, is progressive aortic regurgitation and membranous or infundibular VSDs. Class 2B indication is someone with the VSD and a history of endocarditis. As I mentioned before, closure of that defect reduces the risk of endocarditis. Now, contraindications to closure is basically elevated PA pressures, and this is defined as a PA systolic pressure greater than 50% of this systemic systolic pressure, or a PVR greater than 1/3 of the SVR, or if there's a right to left shunt. Now, back to our case, the patient was eventually transferred to Emory Midtown and eventually got a surgical closure of the Gibboni defect. And this is an echocardiogram taken about 4 days after the closure. And as you can see here, we don't have that jet going from the left ventricle to the right atrium anymore. And this is kind of a close-up view of the fourth chamber. And you don't see that jet anymore. And here are my references, and I'll take any questions or comments.
Thanks, Nish, for that really great review of really the anatomy of the ventricular septum. I don't think I've thought about some of those things in the embryology in a little while. That was really helpful. I'll open the floor to questions. And fellows, we have some of our colleagues from the congenital world here, so this is a great time to ask your burning VSD questions.
Well, this is Joel Harden. I'll kick it off, and I really appreciate that, Nishant. We've got a spot for you if you want to become an ACHD cardiologist. I guarantee you, you will have a job. You will be busy. The population of adults with congenital heart disease won't plateau in the United States until about 2060, and it's exponentially rising until then. So these patients will continue to do what they just did to you, trickle in unusual ways. So
Yep.
Excellent. So a couple thoughts. First of all, yeah, you nailed it on the head. Most of the adult patients you're going to see have undergone repair unless they've moved to us from a resource depleted part of the world, where resource poor part of the world, where they just didn't have access to care, and it's those patients that seem to dominate the ACHD community here in the United States, is the large VSDs that never got identified during childhood, and or the rare patient that has another form of congenital heart disease that is encompassing at least a large VSD, like an AV canal defect or AV septal defect. So those are going to come down the pathway of Eisenmenger physiology and all the downstream badness that goes along with that. The small muscular VSD, inconsequential, as you said. I mean, nothing that you need to worry about that. It makes a nice, interesting noise, though. So you're going to get a lot of people that may refer you patients as cardiologists. And I just want you to kind of feel comfortable if you feel that the echocardiogram is quite clear and you see a small muscular VSD. It's going to make an interesting noise, but it's an inconsequential diagnosis, except for the very, very rare occurrence of endocarditis. So get ready for those. They will come your way, and people are going to freak out about them until you reassure them. So yeah, very good. And then one other thing, just to be very clear for the, since you guys are in an academic institution, by doctrine, at least at the centers that are accredited adult congenital centers, you want to loop in your adult congenital team when you're contemplating a treatment plan for the congenital VSD. We won't necessarily have much expertise to offer you in terms of the post-infarct VSD, but for a congenital VSD, loop in your adult congenital heart disease team before you pull the trigger on a surgical intervention. There are some pitfalls we want to keep you from stepping, landmines we want to keep you from stepping on, and that is one of our roles, is to help people that encounter patients that might need a surgical intervention with any form of congenital heart disease in adulthood before a treatment plan is deployed. So that's all I had. Great job. I really wasn't. It was really fun.
Thank you.
Hey, this is Mike Brumman. I'm one of the other ACHD folks, and I wanted to echo Dr. Hardin's comments that this was a really lovely summary and review of ventricular septal defects. I wanted to comment on a couple of things. I do think we're here and we're happy to help you. Please engage us. We're always happy to come to the bedside and help you out. So we have added a number of different faculty to the program, and so we're much more available than perhaps in the last few years. So please let us help you if we can. Secondly, I think you must have gone to the adult congenital guidelines to get the indications for VSD closure, and I would applaud you for that. For the rest of the fellows on there is a clinical app you can put on your phone that includes the ACHD guidelines, and that will help get you out of trouble. It'll take you a couple of clicks and you can find the indications and what you're supposed to do and how you're supposed to manage them. One comment about this particular case, I think the reason your patient fell apart is because this was probably not really congenital. This was probably a traumatic event, and they generally are very poorly tolerated if you have all of a sudden a left ventricle to RA shunt. Let's recognize that those are actually pretty uncommon. I would say in 30 years, I've maybe seen 3 or 4 like this. And so this is a very common board question is someone that acutely has an LV to RA shunt, and the hemodynamic consequence of that can be catastrophic, just like this patient. So it's a really nice representation of how these folks will sort of show up and fall apart.
Yeah, and I completely acknowledge that, this is likely acquired from the trauma, but that would be a good leeway into. I feel like we've harped on acquired VSDs a lot in these conferences, so I thought it'd be a good opportunity to discuss congenital VSDs.
Excellent. And one other comment, it is true that device closure of ventricular septal defects, some of those primarily in the muscular septum, although right now in the United States, the FDA has no approved devices for defects in the membranous or perimembranous septum. The risk to the conduction system is pretty significant. It's relatively close to the AV valve and the aorta. So I would not plan on attempted device closure, at least in this country.
Stan Sherman, what happened to this patient?
Yeah, so the patient eventually got closure of his VSD, and the last 2 echoes I showed that they actually got a good surgical result. He was eventually discharged to SARA. So he got this closure in August, and on my review of the chart yesterday, he hasn't had much follow-up thereafter. I believe he goes to the VA, so I wasn't able to access those records, but he hasn't been hospitalized or anything like that. So seemingly a good result.
Good job. Thank you.
Well, that answers the question. That answers the question that Mike alluded to as a former military physician with the Navy and Marine Corps. He either had a very bad recruiter and medical team that allowed him into the into the service with a large VSD, or this is indeed now very circumstantially suspicious for an acquired VSD. So
yeah,
good job.
Yeah. And I think it was interesting to note, I mean, he had conduction abnormalities, and as was pointed out, a lot of the important conduction anatomy runs through the membranous VSD, so it kind of fits into this whole acquired that he may have had trauma, which kind of caused a turbidity defect, and likely his bundle of His was affected as well.
Which brings up another sort of thing for the ACHD patient population. If you have intracardiac shunts and you're going to put a device in, we really need to make sure that the intracardiac right to left or left to right shunts are closed to prevent stroke risks.
Well, if that is it for questions and comments, I'll thank everyone again for coming today. And again, thank you to our congenital colleagues for all their comments. I learned quite a bit today. And we will wrap up and pick it up next Friday. See everyone then.
The preceding program is copyrighted by Emory University.